Good afternoon, everybody, and good afternoon to everybody at home. Just a few announcements first. Just wanted to let you know that the exhibit hall will be open until 5 today. Our quiet rooms are available in rooms 113 and 14. Our nursing rooms is 116. Please remember, in order to get your continuing education credits, you must complete and hand in the verification form at the registration desks prior to departing your last day of attendance. You can access this PowerPoint and the handouts on the website. And right now I have the honor of introducing Dr. Vollmer. Dr. Vollmer has been a friend to the National Autism Conference for many, many years. He has received his PhD from the University of Florida in 1992. From 1992 until 1996, he was on the psychology faculty at the Louisiana State University. From 1996 to 98, he was on the faculty at the University of Pennsylvania Medical School. He returned to the University of Florida in 1998 and is now a professor of psychology. His primary area of research is applied behavior analysis with emphasis in autism, developmental disabilities, reinforcement schedules, and parenting. He has published over 150 articles and book chapters related to behavior analysis, which I think with all of your research that you have done, that has given us the opportunity to get out there and make an impact on all of our students. He was the recipient of the 1996 B.F. Skinner New Researcher Award from the American Psychological Association. He received another APA award in August of 2004 for significant contributions to applied behavior analysis. He has served as the editor-in-chief of the Journal of Applied Behavior Analysis from 2004 to 2016. He is a fellow of the Association for Behavior Analysis and has received the ABAI Mentoring Award in 2017. It is quite a distinct honor to be able to introduce you to Dr. Timothy Vollmer.
Well, thank you for the introduction, and I really appreciate being invited back to the conference. It's one of my favorite conferences of the year, for sure. For those of you who do not know, I presented the exact same presentation this morning, so I give you a little word of warning that if I have a look of deja vu or did I tell that story 3 times already, it's probably because I presented it earlier today. But I do want to say a few things about the presentation before we get started. Well, first of all, I'd like to thank my co-authors. You'll see there are many here. The people who are listed are either my current doctoral students or past doctoral students whose research contributed greatly to the model that I will be describing today. A second point that I'd like to make is that although you do have access to the slides, you actually have way more slides than what I'm going to show today. Some of them I wanted you to just be able to reference a little bit further if I made a point but didn't go into great detail about it. Some of them have references on there that might help you find the basis of the point and so on. And then a third preliminary point that I'd like to make is that for those of you who have seen me present before, you know that I really do not have an end point to my presentations. These topics that I've brought along for today are things that I could literally spend an entire semester on about 3 or 4 of the slides. So I kind of go on and we talk and figure out where we are and at some point wrap up. So it's not as if I'm trying to get through all the slides or if we come short that we didn't get through it all. I really just kind of want to have an opportunity to present the basics of the model that I'll be introducing to you today. I also will be asking you for questions prior to a break and then again at the end. And for me, the question and answer period is the most important part of the discussion, because I think that when you have a question, it probably means other people have a related question, and it's something that we should flesh out. So I'd rather spend time on that than making sure we get through all the slides and that sort of thing. So again, don't feel like you have to let me get through. Feel free to ask questions that you have, and I certainly would like to leave open some time for you to do that. For those of you who saw my presentation last night, I gave a little bit of my background, and you heard some of it in the introduction today, but I wanted to point to some specifics about my background that relate to how this consultation model that I'll be describing today has been developed over the years. It started with my doctoral training, where I worked at the University of Florida, where I am back now, with Brian Iwata as my doctoral advisor. Some of you probably recognize the name Iwata, some of you may know him. He was one of the pioneers in functional analysis research, and his group published the seminal article on functional analysis that has been cited in the research literature and textbooks thousands and thousands of times. And I had the good fortune to work with him as a grad student before very many of the treatment studies based on a functional analysis had even been done. So I got involved in functional analysis and behavioral intervention at that early stage of my career. In my first job as a professor, I went to LSU and I was hired into a school psychology program. At the time when I had worked with Brian Iwata, we were working with adults in a state residential facility in Florida. But when I was hired into the school psychology program, I was working with children in schools. So I had to sort of translate what I had learned in the state residential facility with adults and learn how that applied to school systems and school districts. And so a large part of the model that I am describing today started then, when I started to interact with teachers and principals and parents and students, and encountered many of the complications that arise in that type of setting in comparison to a much more controlled residential setting, if you will. I moved to this state in 1996, where I briefly worked at the medical school at the University of Pennsylvania, and that experience was also critical to my understanding of severe behavior disorders and the development of this model, because what I saw in that setting is that there is an interaction between medical variables and environmental and behavioral variables that is not often described in our research literature. And it is in fact a point of emphasis for today that I will start out talking about and then come back to throughout, is that really we need to grasp our scope of practice, what we are trained to do, and understand what we are not trained to do, and when we need collaboration and consultation with some of the types of behavior that we are addressing. And then finally, in 1998, I returned to the psychology department at the University of Florida, where I have been since. I direct the behavior analysis research clinic there, and now I'm involved in a university-wide autism and neurological disorders program that is multidisciplinary. So all of those experiences, I think, contributed to what I'm discussing today. I also would like to point out that, and I think many of you know, that the audience at this conference is mixed in terms of who attends. We do have a lot of board-certified behavior analysts, and there are many in the audience today who are board-certified behavior analysts. Some of you I recognize from meeting here and other places. But we also have other professionals, such as speech-language pathologists. We have teachers, we have parents, we have special educators. So I do want to spend a little bit of time reviewing some of the basics about the operant functions of behavior disorders. And for those of you who are board-certified behavior analysts, some of that will be review, but I hope that as I go through it, I'm able to present some of the information in a manner that you may not have previously considered. And then I will move to the presentation of the model, the consultation model that I'll be describing today. And when I initiate that point of the discussion, I will try to point out how this discussion deviates in ways from presentations I've given previously at this conference for those of you who have attended, whether from home or in the live audience. So one of the things that we have learned conclusively from the research literature over the last 40 or so years is that a very high percentage of severe behavior disorders, and by that I mean self-injury, severe aggression, property destruction, behavior of that type and of that intensity, is learned operant behavior. So what that means is that the behavior is sustained or maintained because of the consequences that it produces. And for those of you who are not behavior analysts in the audience, operant behavior is behavior that is controlled by its consequences. I use the example frequently of turning on a light switch. So if you were to walk into this room and you were the first one here and it was dark, probably the first thing you would do is scan for a light switch and flip it on. That behavior is reinforced or maintained by the fact that the light comes on in the room. So the consequence of your behavior maintains it. And you learned that as a child, and that was maintained throughout your life. If you walk into a room and you flip on the light switch and nothing happens, you might try it a few times, but you won't continue to do that. Well, similarly, our students and clients sometimes engage in behavior that produces a certain consequence, like an attentive response from an adult, or maybe it gives them access to some highly preferred tangible item, or maybe it terminates an instructional or therapeutic session in which they are engaged. And that consequence, although inadvertent, certainly not planned by parents or teachers or therapists, is enough to sustain or maintain their behavior. So when we talk about socially mediated positive reinforcement, I'm referring to reinforcement that is delivered by another person. So it's socially mediated. Positive means delivered in some way. Reinforcement means to strengthen. So in the same way you might say strengthen the wall or reinforce the wall, we're talking about strengthening behavior or reinforcing behavior. Some examples of socially mediated positive reinforcement would include something like a comfort statement from a parent, where perhaps a child is banging her head against the wall and the parent might take the child and soothe her and say, calm down, it's okay. The child might learn this is a way to get mom or dad's attention or teacher's attention or big brother or big sister's attention, even though that person isn't planning to reinforce the behavior. They're doing what any care provider would likely do because they want to comfort the child. They want to see the behavior stop. And in fact, that sort of gets at the idea that the care provider's behavior is also reinforced. It's reinforced by the termination or cessation of that head banging that the child is doing. So the parent's behavior or the care provider's behavior is reinforced by the offset of the problem behavior, and the problem behavior is reinforced by the attention that is received. When I presented last year at this conference, I gave an example from fairly early in my career about a child who I was observing at his home with one of my graduate students, and we watched the child for a couple of hours and didn't see any problem behavior. At one point we went to the family dining room table and were speaking with the parents, and they were describing when they see the problem behavior, and they were surprised we hadn't seen it, and so on and so forth. At one point, the child walked behind his father and started to go toward the kitchen. And the father said to us, "He's about to do it. What should I do?" And I said, "Well, we're here to see what you normally do, so just show us how you would respond." And sure enough, the child stopped at the refrigerator and let out a very loud, piercing scream. The father stood up, went over to the refrigerator, opened it, and started pulling things out, like milk. Screaming didn't stop. Orange juice. Screaming didn't stop. Iced tea. I don't remember exactly what it was that hit on it, but one of the things, the child stopped crying. He poured him, let's say, a glass of orange juice, and it was done. So think about that from that operant sort of interpretation that I just described. The child who could not speak engaged in behavior that was reinforced by the father, who was doing what any parent would probably do, and that is try to appease or assuage the discomfort of their child, but in so doing inadvertently reinforced the child's behavior, and the father's behavior was reinforced because the screaming stopped, right? So that's the kind of vicious cycle that families and teachers get into. They're doing the best that they can. This is not an intentional process, and that's what makes it all the more difficult to develop interventions. However, as I will show early or later in this presentation, when we find that the behavior is socially reinforced, as in those examples, that's actually a good thing, because we know we can treat that behavior fairly easily, or at least based on what we know from our literature. Sometimes the behavior is socially negatively reinforced. This would be the case such as when a teacher walks up to a student and says, "Hey, Sue, it's time to do your work." And Sue starts to bang her head or bite her hand, and the teacher says, "Never mind, we'll do it later," and walks away, and Sue stops engaging in the self-injurious behavior. Well, Sue has learned they leave me alone when I engage in this behavior. The teacher has learned if I walk away, she stops. And so, again, we have that same type of cycle, but it's negative reinforcement in the sense that something stops as a result of the behavior, as opposed to something being presented as a consequence to the behavior. Other examples might include during self-care routines, when a child is resistant to having his or her teeth brushed, or maybe being bathed or toileted or whatever it might be. Sometimes it's even something as simple as escape from a particular situation, such as a loud aversive noise like in a gymnasium or something like that. But the key is that someone inadvertently reinforces that behavior. That's why it's called socially mediated. I will talk extensively about automatically reinforced behavior today. So sometimes even trained behavior analysts are sort of misguided to interpret almost all instances of severe problem behavior as something that is socially reinforced. Sometimes the behavior produces its own source of reinforcement. We're not always sure why, but it seems to be maintained independent of the social environment. So someone hits their head and it produces some kind of pleasing sensation for them, so they persist in doing it even when no one else is in the room. Or perhaps they have a skin rash and they scratch at the skin rash to the point of bleeding because it temporarily attenuates the itching sensation. Okay? So ordinarily, what the task of a behavior analyst is to identify the function of the behavior and develop an intervention. What I'm proposing today is that sometimes there are preliminary steps that one could take before moving into a formal assessment and developing a formal behavioral intervention for the problem behavior. When I've presented here in the past, I've kind of jumped into what I'm going to call step 4 of the stepwise model on the assumption that most would be doing some earlier preliminary steps. But what I have learned in consultation over the years is that many people are not doing some of the preliminary steps or taking some of the preliminary considerations that we might take. So first, before I go into details about each of these steps in the stepwise consultation model, as I've called it, I'm just going to list them out and talk about them briefly and then go into greater detail. It may seem obvious, but a first step, especially in talking about severe problem behavior, should be to rule out medical variables. It is frequently the case, and it's not reported often enough in our literature, that there is an interaction between medical variables and behavioral and environmental events. I'm going to talk about that a little bit more in a moment, but that's really the first step, is to make sure something isn't going on medically, or that your assessment can proceed without medical risks. A second step is to ensure that good programming is in place. I can't tell you how often I have run into circumstances where an individual is displaying pretty severe problem behavior, but when you evaluate the situation, it is the case that there's really not much going on by way of teaching them something, or that they're not learning new skills, and therefore their time is taken up with problem behavior as opposed to being taken up with things that we all do, like leisure time activities, social interactions, and so on. And I'll talk about that more shortly as well. Third would be to evaluate whether the environment generally is providing healthy contingencies. And what I mean by that is that there is a tendency in many environments for the adults or the care providers to inadvertently strengthen problem behavior or provide more favorable outcomes for problem behavior than they do for appropriate behavior. So if a child does something correct or speaks with them, they might say, good job, way to go. But if they start engaging in problem behavior, all heck breaks loose, and there's a lot of attention and a lot of stuff going on related to that particular student. And I'll show some examples of that today as well. But sometimes it is just a matter of switching those contingencies around in the environmental context, not necessarily specific to that student or client. But even then, at times, the problem behavior persists, even in the face of testing for medical variables, making sure that there's a good learning structure in place and healthy contingencies. The student or client persists with problem behavior. And that's when we normally step in with a functional assessment. And it should be a very solid process that involves primarily trying to differentiate between whether the behavior is automatically reinforced, in other words, producing its own source of reinforcement, or socially reinforced. It really boils down to that, because if it's automatically reinforced, there's a certain treatment path we must follow, and frankly, the prognosis is not as good for automatically reinforced behavior because we can't control the reinforcement contingencies as well. But if we find that the behavior is socially reinforced, the prognosis is pretty good. So number 4 is really what I talk about most of the time when I come to this conference in one way or another. Today, I won't talk about it as much in terms of the process of functional assessment. I think there's a lot out there on that, but I will touch on it in relation to how it fits in with this model. Fifth is care provider training. Again, some of you were at my discussion last night, and I emphasized the importance of competency-based care provider training. So it's not effective to simply tell care providers what they should do in terms of implementing a behavior intervention plan. The training must include a test for their actual ability to competently implement the procedure. Otherwise, it's destined to be relatively ineffective. On the other hand, if they can be competency trained, we now have some really good data to show that even in highly complex environments like classrooms and homes, we see significant shifts and changes in the frequency of the child's problem behavior. And then what I'd finally like to discuss today is some impediments to effective treatment. What I think has happened over the past couple of decades in our literature is that there is a bit of a selection bias for what gets published. For example, authors, experimenters, researchers sometimes self-select and say, well, this will never get published because we didn't get very good results. When they get the nerve to actually submit something that doesn't have that clear of results, sometimes the editorial board members will look at it and say, well, the results are not very clear, so we're not going to publish that. And as a result, we have a literature that is primarily filled with examples of socially mediated reinforcement and treatments for behavior that is very clearly socially mediated. But there are a lot of other possible reasons why some of these significant and severe forms of behavior are occurring. So I want to touch on those a little bit today to put some ideas out there for you to consider, and maybe we can look at that, explore it in future research, or certainly take it into consideration in our day-to-day practice. So let me start with a little bit more discussion on ruling out medical variables. As I see it, there are at least 3 ways that medical variables might influence behavior. You might just sort of think of it as from the antecedent side, the behavior side, and the consequence side. And I called the first one illness, but the same could be said for things like genetic characteristics, where some of these characteristics or illnesses might be chronic, they might be reoccurring, or they might be acute. So, for example, suppose one day you are at work and you have a severe headache, maybe it's a migraine, and your supervisor comes up to you and says, I'm in a rush, I need this report and I need it in a half hour. You might be able to say, you know what, I realize it's important, but could my colleague Bill do it? I'm really experiencing a bad headache. But what if you didn't know how to say that? Or what if your supervisor didn't accept that? And you were then forced to do this activity and you were very uncomfortable doing it. That could interact with some inappropriate types of escape behavior, like leaving work, maybe not getting the work done, maybe not reporting that it needs to be done, and so on. Well, similarly, our students and clients might have those types of things, chronic headaches, maybe occasional headaches, an acute illness, and they either can't tell us, or when they tell us, we don't necessarily recognize that it's a problem, and we continue with whatever activities are scheduled for them on that particular day. So what I'm suggesting is that we should be aware of and rule out any of these types of genetic dispositions someone might have. So an example that came up this morning was Prader-Willi. Prader-Willi syndrome is one where individuals have a virtually insatiable appetite, and so they will seek out food to almost no end. And without knowing that about individuals with Prader-Willi, someone might not understand why certain problem behavior occurs. Now, that doesn't mean we can't still implement behavioral procedures, but we need to be aware of that aspect of the disorder. Medication is, of course, a variable. I think anyone who works with students or clients in this room, or if you have children of your own and you're a parent, you know that changes in medication influence behavior, sometimes in a positive direction, sometimes in a negative direction. And when I say influences behavior, I don't necessarily just mean the problem behavior that you are focused on. It could be their academic behavior. It could mean their drowsiness or many other variables like that. So we know that. We see it all the time, but there are very few studies in the literature that point to specifically the interaction between behavioral interventions and medications. But if someone is reporting to you that I see a significant change in this child's behavior, one of the very first things that you should rule out is whether or not there was a medication change. So it could be illness, it could be a medication change. You also need to be aware of possible medical sequelae or outcomes of your assessment or outcomes of the behavior during your assessment. So I always tell a story about when I went to a school. I was brought in as an expert on self-injurious behavior, and the boy was probably somewhere between 15 and 17, an adolescent with very severe self-injurious behavior, and they wanted me to do a functional analysis of the self-injury. So what I did first was I just talked to them to get an idea what this behavior looked like. But what they described is that he would walk up to corners, like of desks, of concrete walls, whatever he could find, and start bashing the front of his head on that corner. So I looked at it and said, you don't have a physician here, right? No, this is a school. We don't have a physician. Do you have a school nurse? Well, no, she rotates through on Thursdays. Oh, okay. Well, we're not doing a functional analysis here. It's not that I couldn't or that I didn't know how, but if any single instance of that behavior occurs, I'm not trained as a behavior analyst to know, could he detach his retina? Could he get a concussion? And so some of you might be thinking, well, but the pages of JABA are filled with functional analyses of severe self-injurious behavior. True, but if you look at where those studies were done, they're often done in hospital settings where there is an interaction between the behavior analysts and medical personnel, physicians, nurses, and other medical personnel. So sometimes getting a consultation about whether or not you should even proceed with your assessment from a medical standpoint is going to be important. So if you recall the order of things here, what I'm suggesting is that any one of these medical variables could influence whether or not you proceed or whether or not you need to proceed. So if you have good data, maybe the medication variable is one that could be corrected. Maybe there's an illness that is temporary and no one discovered it because the student or client doesn't know how to talk about it. But if you suspect that, or at least say, let's rule out, for example, an ear infection or an abscessed tooth or whatever it might be, that's a critical first step, and it's one almost never discussed in terms of what happens when a behavior analyst takes on a case in a consultation arrangement. Second, making sure that good programming is in place, and the purpose of this is in part establishment of earlier learner repertoires, and that's the example I'm going to give, but it holds also for adults and adolescents, because if they're not learning replacement skills or skills in general, it makes sense that they would spend more of their time displaying problem behavior. So just think as an example about earlier learners and some of the skills that are important. We talk frequently about social interaction skills. Well, imagine how much of your day, on a typical day, is spent in some way interacting with other people socially. whether you're talking to them on your phone, emailing, texting, having lunch with them, working with them, chatting with them at dinner, whatever it might be. If you really plotted out your day, most of the time, for most of us in this room, a fairly significant percentage of our day is spent in social interaction. Well, if you don't know how to initiate social interaction, then you might start to engage in aberrant means of getting that social interaction. Or if social interaction is not established as a reinforcer for you, then there's a whole bunch of your day that is spent not engaging in social interaction and therefore needs to be filled up with something else, and unfortunately gets filled up with problem behavior all too frequently. Some fairly standard developmental processes, like responding to one's own name, can be critical. If there's no evaluation of whether someone responds to their name, then we don't know really how to present instructions to them or how to gain their attention when information should be relayed to them. I include potty training on here, which might be surprising to some of you, but if you think about it, if you're a teacher or a behavior analyst or a parent, think about how much problem behavior can occur surrounding things like changing of the pull-ups, or trying to get someone to go into the bathroom, or embarrassing situations when the child wets his or her pants. Even placement issues revolve around potty training, and if someone is effectively potty trained, they can be moved to a more enriching environment, for example. The same is true of self-care skills. And I'm not going to go into verbal behavior too much because this conference is rich with talks on verbal behavior that you can attend. But of course, development of verbal skills is crucial in terms of replacing problem behavior or occurring in lieu of problem behavior in the developmental process. So this stems from what I'm calling step 2 in the stepwise model, and that is you should ensure that teaching and effective learning are going on with these types of skills and other skills for individuals. This has become a focus of research in my particular applied laboratory because we are hypothesizing that some of the correlational research might actually represent causal research. And what I mean by that is that there are correlational studies showing that the more advanced the repertoire that an individual has, the less likely they are to engage in behavior such as physical aggression, self-injurious behavior, stereotypy that interferes with learning opportunities, and so on. So we know that's a correlation, but what if there's a cause and effect relation? What if teaching people those skills makes it less likely that they are to engage in problem behavior? So we're conceptualizing it this way. There's only so much time in the day, right? So if this circle represents all the time in the day, if someone has relatively low self-care skills, relatively few leisure activity skills, and relatively few skills in their work or school place, that leaves a lot of time in the day for engaging in problem behavior that either produces automatic reinforcement or produces socially mediated reinforcement in the form of escape or attention or access to tangible items. Whereas an individual whose repertoire is more sophisticated or has learned more leisure skills, more work and academic skills, more self-care skills, that in itself just leaves less time for engagement in problem behavior, independent of what the function of that problem behavior is. So as an underpinning or a backdrop to all of our behavioral interventions, we should, from a standpoint of ethics, ensure that effective teaching and effective learning opportunities are available for that person. So when we talk about behavioral treatments like differential reinforcement, it's on the assumption that all the rest of this is going on. It's the whole package is the learning opportunity for the individual, because we want to go from something like this to something like this. So I'll give you a couple of snapshot examples without going into details about the studies from our lab, but just to give you a little idea of how we're going about addressing this. A series of studies by one of my doctoral students, Sam Morris, focuses on social interactions. And he is interested in the question, first of all, upon first meeting a child, let's say at a new school, at a new treatment center, is social interaction a reinforcer for that child? Because if it is, that's a good thing. We can use social interaction as a reinforcer. We don't have to use as many food reinforcers and so on and so forth. And they're going to be working with a therapist or a teacher or a paraprofessional, whoever, so it's a good thing if it is. Now, the literature, the diagnostic literature, suggests to us that people with autism spectrum disorders would be less inclined to find social interaction reinforcing, but I'm not so sure that's true. I think any of us here can think of kids who, when you first see them in the morning, they run to you, grab your hand, let's go. Some of them cry when they have to leave you. So I'm not so sure that all individuals with ASD, in fact, based on our data, some of which I'll show you, I know it's not true. Some individuals with autism spectrum disorders seek out social interaction. Others do not. So when they do not, it should be one of our initial objectives to establish social interaction as reinforcing. And again, without going into great detail, I'll show you a little bit about how we go about this. What Sam does is he simply observes for brief sessions, like 5-minute sessions, children entering into a room. One half of the room has toys and an adult therapist on one side. The other half of the room just has toys. And what he has found is that some of the kids tend to go where the adult therapist is and hang out there. Other kids tend to go in the exact opposite direction. And in fact, if the therapist moves to that side of the room, the kid leaves. Other kids are indifferent. But his point is that this is an important initial assessment to do, and it can be done very briefly. So for example, this one with Davis took 15 minutes total. And what he found was that Davis was very social. He would go to the side of the room more than 75% of the time when the adult therapist was over there. What the data on the right show that say risk ratio, without going into details of the statistic, it simply shows that when the therapist moved, I always say, when I move, you move, but when the therapist moves, the kid moves. They go over to where the therapist is. That's why it's not 100%, because it takes a minute for the kid to get over there. Then when the adult moves to the other side, the kid moves to the other side. So it's more than that. This child is more than 4 times likely to follow the therapist than to go to the side of the room that is alone. So that's a good outcome. Another outcome is something like this, where we find that the child spends less than 50% of the time where the therapist is. And in fact, if you look at the risk ratio, the child actually moves to the side of the room where he would be alone. So the therapist goes over to join him, the kid goes across to the other side of the room, and so on. So this is the exact opposite of the first example. So when we get outcomes like this, we simply pair the therapist with some type of preferred reinforcement, hopefully some kind of social reinforcement, and get a reinforcement effect. There's nothing magical here, just a reinforcement effect for going to the side where the therapist is. But importantly, when we look at the risk ratio, where it says V, that is the condition in which a therapist is just simply providing vocal interaction like, how are you today? Good to see you. Thanks for coming over here. The V plus P is where it's vocal plus some preferred interaction or preferred item. And what we see is that when we go to that preferred condition, the child now approaches where the adult is. And we have found this repeatedly with children who were initially avoidant, such as with ACE. So we've now run 20, 30, maybe more kids through this protocol. And to me, the interesting thing is many of them require no pairing of that sort whatsoever. They already are social in that sense, which contradicts the diagnostic literature. So what about response to name? I would suggest that there are two important features to responding to name. One is that the child will look when their name is called, and two, that they will look when it is their name called as opposed to someone else's name called. This becomes critically important when you think about typical child development with respect to responding to name. This developmental chart shows that, that typically at about 5 to 6 months, an infant will start to show responsiveness to their own name. At around 9 months, the Centers for Disease Control, the CDC, recommends that one should consult with your physician if your child is not responding to name. And by 12 months, it's considered a developmental red flag if the child is not responding to his or her own name, and it often is one of the initial stages of a diagnosis of autism and or intellectual disability. So for whatever reason, children without autism spectrum disorders or intellectual disability tend to pick up the skill of responding to their name without explicit teaching. One of my former doctoral students, Danny Conine, who's now an assistant professor at Georgia State, has explored actually teaching people to respond to their name. In this particular slide, what you will see is that for Felicity, in terms of percentage of response during the first condition, here, she responds to her name more than she responds to some randomly selected name. The randomly selected name is the open circles, but only about 20% of the time does she respond to her own name. So in T1, which is our first level of treatment, we simply reinforce looking at the adult in the general vicinity of the eyes when the name is called. Now, an interesting effect, and one that we commonly see, is that the child starts looking no matter what the therapist says. So if the therapist says Felicity, she looks, but if they say Trinity, she looks, or if they say Patricia, she starts to look. And you can see that in the 4th and 5th sessions of treatment 1. But over time, she starts to make a differentiated response where she's only responding to her name and not to the randomly selected names. So we got both outcomes that we want. She's reliably responding to her name, and she's not responding to other people's names. I don't show it here, but the next phases of our treatment are to thin out the reinforcement schedule to a variable ratio 10, and then to train the parents to conduct this procedure. Typically, we get asked, why a variable ratio 10? Like, should you really have to give a child a treat or something for looking at their name, or for looking when their name is called? Our argument for so doing is that probably simulates what happens in our lives, right? Sometimes when people call your name, they're going to give you like some good information, or like, Tim, watch out, and I would have bumped my head, or Tim, did you want this coffee? Sure, great, thanks. Not every time. Sometimes they're going to say, Tim, you've got a pile of work to do for me or something like that. But every so often, intermittently, it's reinforced. And so we believe it simulates what happens in real and in everyday interactions. In this case, for Lydia, in the early stages, so we did a treatment 1, which is again, just reinforcement of responding to her name. A treatment 2, which is where we enhance the reinforcer with not only a food item, but a leisure item. And then we started introducing prompting, and it wasn't until that point later on in the intervention when we were able to see both that increase in responding to name and the differentiated responding that you see in T3 in this diagram. Potty training. So let me give a little bit of a background about our interest in potty training. I told you that we see it as a critical skill for placement, for development, and for essentially avoiding the development of a lot of other types of problem behavior. Some of you may be familiar with a study by Brian Greer and his colleagues where they did a potty training protocol in a preschool that was made up of primarily typically developing children. In their study, I think there were 20 participants, 19 of them were typically developing. The treatment package that they used, although they evaluated each individual component, was 1, they had the child wear underwear instead of diapers or pull-ups. 2, they used a regular sit schedule, go to the potty, sit, and they used differential reinforcement. If the child voids in the toilet, they reinforce that behavior. Makes sense. Interestingly, if you look at the literature in intellectual disabilities and autism, what you'll find is that much more intensive potty training procedures are commonly used. This stems back to the days of the famous Azrin and Fox toileting technique. If you have read the Azrin and Fox technique in recent years, you'll know that many parts are not doable. You can't, for ethical reasons, implement Azrin and Fox, but others have adapted it to modern times, like LeBlanc and colleagues have an intensive potty training protocol that they use, and it's very effective, no doubt about it. But we were interested in the question of what if we just used the same potty training protocol that is used for typically developing kids in preschools and at home? So we used the Greer et al. Procedure, knowing that we might have to go to something more intensive for some of the kids. In our initial study, plus some that we've conducted after, I'm guessing we're at about 20 kids or so now, and we've seen basically 4 different outcomes. The first thing that we do is we simply take a baseline, and in the baseline, we just give them scheduled toileting times. That works for almost no one. However, I will say that 2 of our kids responded just to being told, like, okay, now it's time to go potty. So the closed symbols is appropriate urinations. Now, they weren't self-initiating, but they were using the bathroom. So we didn't put them through the training protocol, but that was only 2 out of about 20 or so. The next level of responders we called the rapid responders. These are people who, within 10 days of the training, started urinating on the potty. And again, all we did was put them in underwear, schedule their sits, and differentially reinforce voids in the toilet. Now this just shows the initial acquisition. We went on to generalize it, thin out the schedule, et cetera, but it shows you that fairly rapidly they responded. The next level of responder were ones who took about 20 sessions or so, or 20 days of sessions before they acquired the skill of voiding in the potty. And then we had those we called delayed responders. These were kids who took sometimes 40 to 60 days, but still acquired the skill. So far we've had 2 kids who required much more intensive potty training. One of whom, with the intensive potty training, acquired the skill. The other one, to date, has not. But I think it's important to note that about 90% or so of our kids have responded, sometimes rather slowly, but sometimes very, very quickly, to the same type of potty training protocol that typically developing kids are given. That's important, I believe, because sometimes placement decisions are made, for example, about where a child will go to preschool based on, well, they're not potty trained. But if other kids who are not potty trained are going through the same type of protocol, there's no reason it shouldn't at least be tested for that. Or that parents might not, they might shy away from potty training because the intensive parts take up so much time at the outset, whereas maybe the same one that they used with their other child isn't so intensive. So we think the preliminary results are pretty encouraging. And I show it not so much to say, here's a way to do potty training, but rather that if we all agree that being potty trained is a critical skill that might help interfere with some aspects of problem behavior, then this is certainly a skill that we can fairly easily get put into place. Same with other self-care skills. I won't go through the protocol other than to say we just basically develop task analyses, use behavioral chaining to teach things like hand washing, folding towels, dressing, other skills of that sort. Again, with that notion being the more of that time circle we can take up, the better it is and the less likely the problem behavior will occur. Also, if these skills are acquired, we're much less likely to engender escape maintain behavior or to have the children develop escape maintain behavior as a result of not knowing how to get dressed or not knowing how to use the potty. So the third component of the model relates to the establishment of healthy contingencies. So assuming there are no significant medical variables at play, or at least those that can be controlled have been controlled, and assuming that there are good learning structures in place and teaching structures in place, one of the common things that we see is that the environment itself has essentially backwards contingencies. And what I mean by that is that the problem behavior is more likely to produce reinforcement than the appropriate behavior. So this step of the consultation model involves flipping that around, teaching people in general, for the general environment, to reinforce appropriate behavior and minimize reinforcement for problem behavior. In fact, for those of you who have seen me talk here before, I have given an entire discussion about the notion of minimize and maximize. We tend to use that as just sort of a simple way of remembering how to implement contingencies in classrooms, in family structures, and other complex environments. We have found it's very difficult for teachers to sustain a procedure where they have to use timers and clickers and reminders and counters, but minimize, maximize is fairly easy for people to remember and to implement, including parents and other care providers. So we minimize reinforcement for what we don't want to see, and we maximize reinforcement for what we want to see more of. Why do I say minimize instead of ignore the behavior? Well, the reason is that much of the time, the type of problem behavior we're discussing today really cannot be ignored, right? You can't ignore aggression. In fact, going back to my talk from last night, you might put yourself at legal risk if you tell someone to ignore the behavior. There have actually been legal cases where it came back to a teacher saying, well, that board certified behavior analyst told me to ignore the behavior. Look, it even says it right in the written behavior plan. It says, ignore the aggression. Well, really what the behavior analyst meant was just react as minimally as possible, but that's not what they said. They said ignore. So we don't use the word ignore. I don't ever put it in any written plans. I don't ever teach it to parents. I don't teach it to teachers for that reason. But we can minimize. We don't have to start shouting. We don't have to pull the student up to our desk and have a conversation with them when problem behavior occurs, although we can do all that when some appropriate alternative behavior occurs. We can make a very big deal of it because we want to see more of that. Healthy contingencies also involve environmental enrichment and non-contingent reinforcement. Environmental enrichment simply means making sure there are other things to do, especially during downtime. What I've seen in many school situations is teachers might nicely have learning modules in place where they rotate around the classroom, but those who are on their free time are looking for what to do, and there's nothing readily available, when simply enriching the environment with preferred items specific to that child or that group of children would help eliminate some of the problem behavior, especially automatically reinforced problem behavior. Similarly, non-contingent reinforcement schedules like non-contingent attention are useful because they reduce the motivation to engage in attention-maintained problem behavior. So if someone is coming around and saying, everyone in this group okay? Can I get you anything? Everyone all right? Nice to see you. I'll be back in a little while. Then they're getting attention freely and frequently, so they do not have to engage in the problem behavior to get that attention. And the research on that has been around for many, many years and supports that notion. So the point is to, at this stage of the consultation, make sure these kinds of arrangements are in place. And if they're not, help to get them in place through training of the parents, care providers, teachers, or whoever it might be you are working with. So that's what I call healthy contingencies. So it's really only at that point, at least in our consultation model, where we start to conduct a thorough functional assessment, because you can do an assessment, but if all these other things are not in place or have not been checked on, you really could have your back up against the wall and not know why. Like, just think about the medical variables. If you start a functional assessment and you haven't considered medical variables, you're probably going to end up having to go back and reconsider those medical variables. So today I'm not going to go thoroughly through the functional assessment process. I think most people here are familiar with that. I will talk about some new developments that we're working on in functional assessment and relate that to sort of differentiating between automatically reinforced behavior and socially reinforced behavior. But before I get into that, I'd like to open it up at this point for questions. And I think we have a microphone because we're on live feed. So if anyone has any questions about those first three steps that we talked about. Yes, over here. Do we have the microphone? Okay.
Hi, I just had a couple questions about the toilet training. How many children did you do this with?
Well, in the study that we are right now submitting for publication, let me think, we had 2, 5, 9, 11.
Okay.
And subsequently, I believe we have about 9 more. So I think it's a total of about 20.
Okay, and then with the toilet training, I know you said that you kind of used the model for typical children.
Well, that was the Greer study from which we adapted the procedure, yes.
Okay. Did any of those children have other diagnoses than autism? Like
In the
medical?
Greer study?
No, in your experience.
No, all of our children were ones diagnosed with autism spectrum disorders.
Okay, so they
yeah.
didn't have any co-occurring medical or?
Not to our knowledge. Now, we're beginning to suspect that some of the ones who have required intensive intervention, by coincidence, the first two also had pediatric feeding disorders.
Okay.
And we have a specialist in our lab who does work in pediatric feeding disorders, and we've sort of evolved this hypothesis that the two might be related in some way, that if we can treat the food refusal, or at least the picky eating, which is a whole other discussion for another day, but if we can treat that some of the difficult toileting issues might resolve. Okay. So that's a protocol we have developing right now. But in terms of other diagnoses, to my knowledge, no. It was primarily ASD.
And did you do any parent coaching or anything like that?
Interesting. It's funny that you mentioned that, because that was the plan. But all of the kids started using the potty at home after they were trained.
And
this was done right at the center. Now, granted, it was 6 to 8 hours a day, but we never had to teach the parents. So
where are you located? No, I'm just kidding.
And it's funny that comes up, because a lot of times when I've been working in schools, teachers will say, yeah, I've potty trained him, but they won't do it at home, or vice versa. And it didn't happen. We were very much expecting, once we figure it out for this kid, we'll train the family. But the kids started coming in underwear, and the parents would say, oh yeah, he's been going at home. So it was a nice positive side effect. We didn't capture it as well as we should have in our data, but now we're starting to explore that a little bit more. Yeah. Other questions? It's funny, because now that we're on live stream, no one will ask questions, but this morning we had lots and lots of questions. Don't be shy. Try it, because if you have a question, other people probably have a similar question. Yes.
I'm interested in any studies on automatic negative reinforcement.
None. There really aren't any. And that's one of the things I'm going to talk about later when we talk about impediments to effective intervention. None have really isolated the fact that it was specifically automatically negatively reinforced. But there have been experiences I have had that very strongly lead me to believe that was what was going on. For example, I once knew a young man who at certain times of the year would scratch himself all over his body to the point of bleeding. And this was back in the late 1980s, and those times of year they would literally have him strapped down to a bed because they didn't know what else to do. At some point, a couple of years later, and this had been going on for years and years seasonally in his life, they figured out there was an allergy, and they treated the allergy. Now, to me, that's evidence of automatically negatively reinforced behavior that was treated by treating the medical variable. But that's also an example of the type of evaluation that would be very difficult to get published, because reviewers, editors, and so on would say, oh, it's all correlational. You don't have a cause and effect design, or you don't have enough replications within the individual or something. But I think those are the kind of reports we need to get out there, because whenever I talk about that, other people start saying, like, oh yeah, I've seen something like that too. I had a kid who had a tooth infection or an ear infection, and the same thing happened. So yeah, there's not much.
I'm a parent of a son with autism and a registered nurse and a behavior analyst. And so I have lots of examples with my own son as well as my clients of where the function was automatic negative and with some treatment. And so I asked the question because I asked the same question to Dr. Iwata a few years ago on a side conversation, and he told me that there were none. And I was like, what?
Yeah.
And it really is a huge issue.
It really is, and it's first proposed in a paper by Cataldo and Harris in the 1980s. That's how long ago this notion was was introduced. And I really believe it's just due to methodological constraints that have been unfortunately guiding our field. And we need to step away from those methodological constraints to advance. And that's really going to be the theme of the last part of my discussion today. But I'm glad you brought that up because it's critically important.
I have a follow-up potty training question too. Just a logistical issue is, with the Fox and Azarin method, and I kind of more similar to what you use in terms of your model, but underwear only, underwear with clothes on top, anything on top to prevent in the homes is particularly troublesome if it takes a long time and you're on sofas, on rugs, and it's a mess.
Well, and let me clarify one thing. So I mentioned the LeBlanc approach, which is adapted from the Azarin and Fox technique, and it's great. Like, probably if I had my own child, I would probably just do that. Because, it's going to be messy, it's going to take some time, but it's going to be done in a couple of days. So I'm not opposed to the intensive potty training. Really, the purpose of our study was to say, if the child was in a circumstance where that intensive potty training could not be done or was unlikely to be done, would they be responsive in a manner similar to children who are typically developing? And so, I think there's going to be circumstances where it's too messy, it takes too long, in which case let's just go to intensive. But we always had the kids wearing clothing over their underwear. They were in a treatment center and around other people. And
Okay, thank you so much.
Sure. Another question up here?
Are there any circumstances where you would have an exception to following this model? I'm thinking of some self-injurious behavior where you rule out medical variables, but then ethically, should you go right to functional assessment and treat that before looking at the other pieces?
Yeah, that's a really good point. By no means do I mean to imply that the order here is necessarily set. Some of the things can be happening concurrently, for sure. You'll even see when the final one that I mentioned is impediments. I start thinking about impediments from day one, really. So you could say 6 pervades all of the other steps. But certainly if there's an emergency situation, there are a couple of strategies to follow, one of which I spoke extensively on last year. I didn't want to really repeat myself, but it's pertinent here. Sometimes what we do is just try to turn off the behavior while the team can regroup. And an example of that is if we suspect, let's say that it's escape maintained, we turn off all instructional demands. And typically when I say that and teachers are in the audience, they'll, what? No instructional demands? But remember, it's an emergency procedure. And in fact, I think that's what I called it when I presented it last year, an emergency procedure. In the olden days, emergency procedures were medications that stopped people from behaving across the board, restraining, seclusion, and so now that we have the understanding of the operant functions of behavior, we can use that to our advantage to create emergency procedures that do not involve seclusion, restraint, and medication. So we could just cut off, turn off the demands so we can breathe and say, where do we go from here? What's going on? What should we explore? Similarly, if it's attention maintained behavior, we can provide continuous non-contingent attention. Again, I often get gasps, but when you look at what's happening in those very severe cases, they're already getting continuous attention. So all we're doing is saying, let's turn it around and just have a social interaction that's ongoing while we take a breather. And one of my former doctoral students, Sarah Slocum, who is now at the Marcus Center in Atlanta, explored that through a grant from Autism Speaks and found that she could immediately suppress behavior, either by turning off the demands, providing free attention, or providing free access to a tangible item. So again, a lot of parents, a lot of teachers, even behavior analysts will gasp when I say sometimes we just let the kid have the iPad all day. Why? Because we'd rather do that than restrain him all day, or send him home from school all day, or have somebody give him medication. We can deal with that for one day while we regroup and treat it as an emergency procedure, not a treatment, an emergency procedure. So the short answer to your question is yes, sometimes we modify the steps, we incorporate them all together, but ultimately all 6 of these steps are things that we want to consider. We don't want to do a behavioral treatment in a situation where the person isn't being taught any other skills. And that's just a really common point of discussion that I've encountered over the years is people will ask, because I'm a big fan of the treatment differential reinforcement of alternative behavior. Another one of my presentations here was called DRA as a way of life. I just think we should all move through the world reinforcing appropriate alternative behavior and minimizing reinforcement for dangerous or inappropriate behavior. But I don't see that as happening in a vacuum. I think that educational processes are critical importance. Teaching typical developmental skills are of critical importance. And if you were only doing DRA and not doing all the rest, you're really not addressing the problem on a larger scale, in my view. So somewhere in there, that would have to be incorporated. Yes, over here.
Hi. In a case in which a child's exhibiting in which they're exhibiting self-injurious behavior and assessment is potentially dangerous, and one has observed that the behavior occurs when the child is alone, and one has observed that the child engages in self-restraint, is there any reason to proceed with a functional analysis, or can we assume that it's automatic?
Well, what I'm going to show in the second half is a way of demonstrating that very, very briefly. If you look in your packet, you'll also see a model that has been proposed by Hagopian et al., where it shows 3 different subtypes of automatically reinforced behavior. Subtype 3 is the type that occurs with self-restraining and automatically reinforced self-injurious behavior. You can detect that very, very quickly. You could do a 10 or 15 minute observation, and if the child is self-restraining or adult is self-restraining through that time, I think it's safe to surmise it's subtype 3 based on Hagopian's data and some of the studies I'll be showing in a little while. I didn't bring the Hagopian work to my slide presentations, but I put it in your package in anticipation of that type of question. Some of you may not be familiar with self-restraining, and I believe it's less common. I would like to see some prevalence data on that. I used to see it a lot, like in the 1980s and 1990s, before a lot of self-injury was treated as well as it is now. But it involves people wrapping themselves up in their own clothing, wrapping themselves up in chairs or furniture. And what it looks like is that they're trying to stop themselves from injuring. And so a lot of times people will say, well, why don't they just stop then? And I relate it to, have you ever been sitting there in your living room with a bowl of potato chips? You just keep eating them. So there's something reinforcing the eating, but there's also something aversive about it. Like, you shouldn't be doing it. You're going off your diet, whatever. So what do? We typically move the potato chips to a different room, seal them up. Sure, we could still walk over and get them, but we've changed the response effort to getting access to the chips. Similarly, I believe, and there's some research by Rick Smith, and I was involved in that research to show that that might be the function of self-restraint, is that essentially they're making it more difficult for themselves to engage in the self-injury. I once knew a young man, he was probably about 22 at the time, who, when he went to sleep at night, would tie himself all up in his sheets and covers, because if those were not available, even in his sleep, he would engage in self-injurious behavior. So, yeah, I would look at the Hagopian work. There's now 2 really nice papers. Both of his studies on that topic have been award-winning research articles in the Journal of Applied Behavior Analysis. And then this, in the second half of the afternoon, we'll talk about some brief assessments that you could probably apply to that problem.
Thank you.
Other questions? In the back corner over there?
Just to go back to the gasping when you're removing all the demands.
Yes, yeah.
I deal with it all the time. How would you document that so that a parent wouldn't be the one doing the gasping?
Okay. So, well, I will typically use the exact examples that I used, that in before the days of understanding the operant functions of behavior, what people did is they restrained students, they medicated students, they secluded students. Those are not considered acceptable under most circumstances for us as ethical behavior analysts and other professionals. But we have a technology available to us now. Even if we haven't done a complete functional analysis of that student's behavior, we know that the research literature shows us a high percentage is escape behavior. And if you can watch that student and you see that every time the teacher is giving instructions, that's when the severe behavior starts to occur, then all you're doing is you're creating an emergency treatment, an emergency intervention that is supposed to be short-lived. And then there is the literature on instructional fading, where you gradually fade back in instructional activity, and as long as you can present a plan for that and present it to the parents, teachers, other people in the school, then say, this is our plan for getting it back, but we need some time to come together as a group and develop an organized plan without resorting to one of these old-fashioned, if you will, emergency procedures.
So you would write up an emergency plan,
Sure,
and
yeah.
review it with
Yeah.
the parent. Okay,
Yeah.
thank you.
Okay, I think we're getting close to where we probably should take a break. It's about 2:40. Why don't we try to return at around 2:55, and then we'll pick up with the second half of our conversation. Thanks for the great questions. We'll resume in about 15 minutes then. In consideration of the people who are watching online, I think we should stick with our schedule and try and get going again, and some people might filter in. In looking through my my notes of what we have remaining, what I'll probably be doing is hitting on certain kind of what I view as key points and also points related to the questions that have been raised so far, rather than going straight through. But I sort of implied early on that that would most likely be the strategy I would follow anyway. But I'll try to sort of point you to the discussion point, and then I'll elaborate from there as we go through. But we definitely won't be going through every single remaining slide at this point. But where we were was at the point of functional assessment, and I had mentioned that I do not intend to go through a thorough description of the functional assessment process for the purposes of this talk. That information is available elsewhere, and hopefully, if need be, I can guide you to it. But really, my main point at this juncture is to stress that really the purpose of a functional analysis or a functional assessment at this stage is to differentiate between when behavior is automatically reinforced and when it is socially reinforced. And the reason for that is that if the behavior is socially reinforced, the treatment for all practical purposes looks quite similar, with a couple of exceptions. And what I mean by that is we typically use positive reinforcement for appropriate behavior, and we minimize any change to the environment when problem behavior occurs. But when the behavior is automatically reinforced, the path of treatment selection is necessarily a bit different because we're not in control of the source of reinforcement for the behavior. So let me talk a little bit about some fairly recent work and work that we're doing currently in my lab related to screening for automatically reinforced behavior. And in the interest of historical background, I would like to point out that I spent the majority of my career, at least in research, doing this exactly backwards. I'm a slow learner, and it took me a while to figure it out. However, I did start to think about screening for automatic reinforcement when I was doing consultation, for example, in schools and in treatment centers. And the way that went for me, or the way it unfolded, is I tried to watch the person when they were alone, when there were no social consequences for their behavior, before I did anything else. And that was exactly the opposite of what I was doing in all of my research, where we would do a full-fledged functional analysis, and if the data were all kind of mixed together, then we would watch them extensively alone to see if the behavior would persist. So I kind of intuitively got a grasp for doing it the correct way, maybe about 10 to 15 years ago. But then Angie Quirum, one of Brian Iwata's former doctoral students, actually tested out that approach in her dissertation research. And what she did was she used a no interaction condition as an initial screening for automatic reinforcement. So the very first thing she did was watched people when there was no consequence to their behavior. And she would do that for about 3 or 4 5-minute sessions to see what would happen. Her hypotheses were that behavior maintained by automatic reinforcement should occur throughout each session. So it should persist in the absence of any social reinforcement contingencies. And behavior that was maintained by socially mediated reinforcement would either not occur because, let's say, if it's escape behavior, there's no demands, so it should never occur, or it should decrease, and that might be an extinction effect if the behavior is maintained by attention. And so this is just a snapshot of some of her results, and this is a published study in 2013 in the Journal of Applied Behavior Analysis, so it's readily available to you if you'd like to see it in more detail. But the important thing to note relates to these outcomes. The essay was her screening for automatic reinforcement, and as you'll see in all of the cases, there were 3 or 4 very brief sessions, and in all of these cases, the behavior persisted independent of any kind of social reinforcement contingency. So her prediction or hypothesis at this point was the behavior is automatically reinforced. Now, because this was a study, she had to go on to demonstrate that with a full-scale functional analysis where all of the other conditions were tested, like attention, escape from instructional demands, etc. But you can see that it's the blurry mess that we have come to associate with automatically reinforced behavior. So in all of those cases, the hypothesis was confirmed. Similarly, in this case of Brad, she showed that although the behavior started out occurring in the screening assessment, it decreased very rapidly and went down to 0 levels by the third very brief session. Then when she conducted her full-scale functional analysis, she found that the behavior was in fact sensitive to attention. So if you look at the 4 sessions with the filled squares, those are all when the therapist was providing attention contingent on the problem behavior. So again, it's a confirmation of her original hypothesis. And then the next one is with Pablo, where the behavior never occurred at all during the screening assessment. When she went on to do the full-scale functional analysis, she found the behavior only occurred in the demand condition, which makes sense. It didn't occur during her screening assessment, because no demands were presented, so the escape hypothesis is confirmed in her full-scale functional analysis. We're doing a replication study of this. My doctoral student, Crystal Slanzy, is leading it. There's only a few differences between our study and hers. One is just to extend it, to show that it applies with more individuals. But Crystal is also doing one long session as the screening assessment. So what I mean by long is anywhere from 11 to about 20 minutes, which isn't really very long, but she's able to make the same sorts of predictions within a very short period of time. Another difference is that Angie Quirum had individuals who were older and a wide range of different disorders, including intellectual disabilities. We're focusing specifically on younger children with autism spectrum disorders, and one reason that we're doing that is we are in the midst of developing procedures to do longitudinal analyses with these children so that we can track their behavior from a functional standpoint over longer periods of time. And then also what Crystal in my lab is doing is she's trying to differentiate outcomes that would suggest the behavior is maintained by attention versus those that would suggest the behavior is maintained by escape or tangibles. So it's really the same sort of study, but the purpose is to try to create a brief and non-intrusive screening to predict behavioral function that can help guide in treatment. So there are certain predictions based on the results from the no interaction condition that we would expect. If problem behavior occurs throughout the session, we predict the behavior is maintained by automatic reinforcement, and the rationale is that there is no social reinforcement and the behavior is persisting, so it must be automatically reinforced. A second prediction relates to that case of Brad that Quirum presented, where we see the downward trend occurring and then the behavior is maintained by attention. So what Crystal Slanzy is hypothesizing is that when behavior occurs during the session but decreases, there's reason to believe that the behavior is socially reinforced by attention, because that looks like an extinction curve. The rationale is that without the delivery of attention, even though there's an adult in the room, the behavior extinguishes over time. And then that third type of outcome shown by Quirum related to Pablo, where the behavior never occurred at all, and then she showed it was escape maintained. Well, Crystal is hypothesizing that when problem behavior does not occur at all during the session, it's either maintained by escape or tangibles, because if it's maintained by escape, you wouldn't expect any behavior to occur because there are no demands. If it's maintained by tangible, you wouldn't expect any behavior because the tangibles aren't even present, nor are they being removed. And so we would expect, under those circumstances, to see zero behavior. The long story short is we're getting almost an exact replication of the Quorum findings. What you might find useful is that we're simply doing it rather than in 3 or 4 5-minute sessions. We're just doing it in one shot. So just watching for 15 minutes. So related to the question about automatic reinforcement and self-restraining, I'm guessing you could do one brief observation and say, based on the research by Quorum and now by Slanzy, we're concluding this behavior is automatically reinforced, and based on the research of Hagopian, it's the subtype 3 of automatically reinforced behavior. I'm not going to go into all of that. Here's another example similar to the Quorum findings for attention-maintained behavior, where the behavior gradually dropped off across 11 minutes in this session. So right there, after 11 minutes, we concluded probably maintained by attention. Then we went on to conduct a more extended functional analysis and found, sure enough, the behavior was sensitive to attention as reinforcement. Then we observed an individual for about 20 minutes and never saw the behavior, which led us to the prediction it's either maintained by escape or by tangibles. And our more extensive functional analysis then showed the behavior only occurred when instructional demands were presented. So combining the Quorum findings with now Crystal Slanzy's findings, we're showing repeatedly that these types of assessments can be done very, very quickly. Anything after the 15 minutes really doesn't have to be done, except for if you want to differentiate between tangible and escape. So here's a case where there was no escape maintained behavior, but it showed up immediately when we tested for tangible reinforcement. And then sometimes we see combined, such as with tangible and escape. Now, I'm not saying these are the synthesized contingencies, such as the sort Hanley has described, because these are isolated. Escape in isolation functions as a reinforcer, and tangible in isolation functions as a reinforcer. So I bring this up not to say this is the entire functional assessment process, but it's kind of a relatively new development, and one that we're extending, that we have found to be very practical, and many people are starting to adopt as a quick way to simply make the determination, are we dealing with automatically reinforced behavior, or are we dealing with socially reinforced behavior, if that makes sense. So what do we do with that information? Well, if it's socially reinforced, that's when we implement that minimize, maximize type of model. The advantage to knowing specifically what the reinforcers are is now we know what to minimize and maximize, whereas we may not have when we were simply trying to develop healthy contingencies. So if, for example, we determine that someone's problem behavior is sensitive to attention, we minimize attention when problem behavior occurs and maximize attention when appropriate alternative behavior occurs. The reason my second bullet says positive reinforcement is that the recent research on differential reinforcement shows that positive reinforcement is the most effective treatment even when problem behavior is maintained by negative reinforcement. So for many years, people simply tried to replace the function of the behavior by teaching things like break please or providing a break contingent on compliance. Well, the research is showing that is less effective than providing positive reinforcement for compliance and participation in the instructional activity. And I'll show some evidence of that from our research and other research very shortly. So when we find out that the behavior is socially reinforced, we typically implement DRA, differential reinforcement of alternative behavior. Many of you have heard me talk about this for many years. It is my go-to treatment. It's what we pick when we know what the reinforcer is. And typically when this is done by a professionally trained behavior analyst, the treatment outcome looks something like this, where we get a high rate of replacement behavior like MANS and low rates of problem behavior because the mans replace the problem behavior in differential reinforcement. Then we, of course, try to signal when the mans can be reinforced and when they cannot be reinforced, all that for another day of discussion. But my main point is the behavior can be can essentially be turned on and turned off using differential reinforcement. That we've known for many, many years. However, what has become very clear in recent years is that there are situations when extinction is not viable. So when a professionally trained individual is implementing DRA, they typically place problem behavior on extinction and reinforce the alternative behavior. But there are many reasons why extinction cannot always be implemented. One of them is that the individual might be larger or faster than the parent, therapist, or teacher. So if it's escape maintained, the person can't physically guide them to complete the task. Or maybe if they're very fast or quick or slippery, they can get under the desk or something before you can even stop them from doing that. So they're going to escape. So we have to have treatments that will be effective in the face of continued reinforcement of the problem behavior. Another example of where extinction may not be viable is for legal reasons. There could be state, local, or facility laws and rules that require blocking of dangerous behavior, even if you know that that physical attention is reinforcing. Maybe you've demonstrated that in your functional analysis, but you're not allowed to allow it to occur. You have to physically block. Therefore, your treatment needs to be able to work in the face of continued reinforcement. Similarly, there may be ethical reasons. You can't include a component of a treatment that places an individual at risk for getting hurt. And this is where that ignore fallacy comes in. So you would not want to tell a teacher, for example, to ignore aggression for ethical reasons. Somebody might get hurt, and then who's going to be responsible for that? Well, probably you, because you said ignore. There are also practical reasons. Even the very best and well-trained therapists make errors. So I've been doing this for decades, and DRA is what I always fall back on. But when I'm demonstrating DRA to parents, teachers, my own students, every once in a while I make a mistake. And when I make a mistake and inadvertently reinforce the problem behavior, essentially I've placed it on a variable ratio schedule of reinforcement. And I've been doing this for years, and I make that mistake. I know my doctoral students who are board certified behavior analysts, they make mistakes because I watch them and I see them make mistakes. So if we make mistakes as trained professionals in behavior analysis, what about parents? They're typically not trained as behavior analysts, although we have a couple today who are here in the audience. Even if the parents are extremely well trained, what about the grandparents? What about teachers, parapros, staff, siblings, friends? You get the message. Somebody's going to make mistakes. So our differential reinforcement procedures have to be able to stand up in the face of continued reinforcement for any one of these reasons. When I talked about this problem more specifically here a couple of years ago, I actually had people jot down reasons why they are unable to implement extinction in particular cases, and we came up with about 30 different reasons. I was just talking to someone at break about elopement. Well, if it's attention maintained elopement, you can't let a child run across the road. You're going to have to attend to that behavior. So your treatment has to work in the face of that. And that's really where the matching law comes in. The matching law, although this sounds like a mouthful, I think that if we walk through it, you'll realize it's fairly straightforward. It posits that in a concurrent arrangement, the relative rate of one response alternative will essentially match the relative rate of reinforcement available for that response alternative. So This morning when I was talking about this, I walked through kind of a thought problem and said, and here's where I'm having the deja vu. I feel like I've already told you this story, but suppose there's a big green button on this side of the wall, and there's a big red button on that side of the wall. When you touch the big green button, on average, once every minute, a $100 bill falls out. If you touch the red button, on average, once every 2 minutes, a $100 bill falls out. First question, which button are you going to press more often? The green, because there's a higher rate of reinforcement available. How much more often do you think you're going to press the green button? Twice as often, because twice as much reinforcement is available. So if I kept you in this room all day long and had that contingency in place, you would be spending almost exactly twice as much time over by the green button. Some people ask, well, why would I ever go to the red button? Well, because you're going to miss out on some $100 bills if you only stay at the green button. So you're going to split your time, but it's going to be double over by the green button. And the reason I'm so confident about that is the matching law phenomenon has been replicated across dozens of species, all kinds of contexts, and including kids with problem behavior. We've been studying it for many, many years, and it's very reliable that if parents or teachers reinforce problem behavior more than they reinforce appropriate behavior, you can predict, based on the matching law, how much the child or student will allocate their behavior towards problem behavior. I'm going to show you this graph again in a little while, but I just want to kind of orient you to this notion with a brief explanation. What we did in this particular study is we observed kids interacting with their parents at their own home. And what my pointer, okay, so the further you are along this axis means the more that problem behavior is being reinforced in relation to appropriate behavior. The higher up on this axis you are, it shows the more reinforcement available for problem behavior. So what's happening is these kids are getting more reinforcement for problem behavior, and as a result, they're displaying proportionally almost exactly the amount of problem behavior you would predict. So what we want to do is teach the parents not to reinforce the problem behavior, at least minimize that, and it should slide down this diagonal, and I'll show you shortly that it does. So the matching law is very useful, but it's also a very helpful model because we already know that sometimes the problem behavior is going to get reinforced. So our task becomes, let's make sure appropriate behavior gets reinforced more than problem behavior. Because if we can do that, the behavior is going to start to get allocated more and more to the appropriate behavior. And we'll see it move that way. Now, there are some other variables to consider in terms of kids' allocation or individuals' allocation to problem behavior versus appropriate behavior. Let's start with what the problem usually is when we are called in to consult on a particular case. Let's suppose it's something like aggressive behavior. The probability of aggressive behavior being reinforced, if it's, let's say, attention maintained, is about 1.0. In other words, somebody is going to have to come over and physically intervene whenever that aggression occurs. But if appropriate behavior occurs, maybe if we're lucky, that gets reinforced on about a variable ratio 5 schedule. So maybe 1 out of every 5 things the student or child does appropriately will produce attention from the adult. And that's pretty good, actually. This is a hypothetical example, but if we saw 0.2, that would be pretty high. But you can see that the probability of attention for aggression outweighs the probability of attention for appropriate behavior. Another variable to consider is the delay to reinforcement or delay to attention. People typically go running when aggression occurs. They have to. But a common response to a hand raise or a tap on the shoulder is, just a minute, I'm busy, I'll come back and see you. And then there's a delay, and also it becomes probabilistic whether the adult will remember to come back. The quality of the attention is different. With aggression, it's typically verbal and physical. With appropriate behavior, it's usually a brief verbal exchange, such as good job or way to go. The attention takes a long time to intervene. With aggression, and saying good job or way to go doesn't take very long at all. So now, instead of $100 bills and green buttons and red buttons, if these were your choices and you are an individual for whom attention is really, really important, it's not difficult to see why someone would allocate their behavior toward the aggression. In fact, it's perfectly predicted by the matching law. Most of the time, if they have a choice between raising their hand and aggressing, they're going to aggress if attention is the reinforcer. So what do we do about that? How do we tip the scales back in favor of appropriate behavior? That's exactly what our job is as behavioral consultants. We're being asked to flip it the other way. So what we have to do is look at the reality of the situation. We can't really ask people to ignore the aggression. So the probability of attention is going to stay the same. But we can teach people, at least initially, to attend to particular alternative responses. The example I gave this morning was about a case in Iowa where I had a kindergartner who had been suspended from using computers in the computer room because he was breaking them. So he would take laptops, smash them, he would take keyboards, smash them, and we did a functional analysis away from the computer room where we just had like pieces of paper, and when he tore them, we'd say, don't cut that out, stop doing that. And we found his behavior was very sensitive to attention. So we taught him to raise his hand, in which case we'd run over, give him lots of attention and that sort of thing. So we thought, let's bring him back to the computer room, let's try this and see what happens. We told the teacher what we were going to do. Her initial response was, well, I can't attend every single time he raises his hand. And my response was, yes, you can, because pretend he's raising the computer keyboard above his head when he's raising his hand, and then you'll run over there because you run over there every single time. So I demonstrated it, and I went running over there when he raised his hand, and he did raise his hand. And he just thought it was hilarious to watch me sprinting across the computer room and huffing and puffing and sitting down next to him, in which case, I would verbally and physically attend to him. So I was giving him fives, rubbing his hand, patting him on the back. I'd pull up a chair, sit down, and talk to him. Whereas my plan, if he were to raise the keyboard again, would have been to just block it to the best of my ability. And blocking it doesn't take very long, but I always made sure to stay there and talk to him for as long as I possibly could to make sure the duration was longer for the appropriate behavior. Now, that's not aggressive behavior, it's property destruction, but it's the same sort of principle, and the same principle we have applied in using differential reinforcement based on the matching law. So now if you look at it, the scales are tipped, however slightly, toward appropriate behavior. And I'm not saying that this behavior would change overnight because the person has a long history with aggression paying off more, but over time, the matching law tells us it's going to tip toward appropriate behavior. And that's perhaps the best we can do under those circumstances, when the behavior has to be reinforced for one reason or another. We actually studied this for the first time in 2010. We've done some other studies more recently, but Elizabeth Athens initiated this line of research where in a baseline condition, she equated reinforcement for classroom disruption. And this student, Greg, had attention-maintained classroom disruptive behavior, and she provided whether it was an appropriate mand or the disruptive behavior. She provided 30 seconds of attention with as close to a 0-second delay as she could. And presumably due to his history, he continued to display high levels of classroom disruptive behavior. In the next condition, we made it where the mand or the request for attention produced 30 seconds of high quality attention. So he liked a high pitched, like, way to go, good to see you. That was the high quality, and we did it immediately. Whereas when he displayed disruptive behavior, we intervened for 5 seconds. We gave low quality attention, which was a reprimand. Stop that, please. I don't want to see that anymore. And we delayed our reaction by 10 seconds. And you can see that now the mand essentially replaced the problem behavior. Now, I will say that this was one of 2 individuals in this study for whom we, what I call, threw the book at them. We stacked the deck completely in favor of the appropriate behavior during the treatment, because when we did it one at a time, it was a very, very gradual change. And we wanted to see if we just changed everything at once, could we change the behavior immediately? And the answer was yes. We went back to the baseline circumstance, problem behavior came back, went back to our treatment, the manding came back, and the problem behavior dropped out. And then in the final condition, we got the teacher involved, and we were able to maintain those effects. So this is an example of where we didn't put extinction in place. It's a model for what if you can't, what do you do? Well, you stack the deck in favor of the appropriate behavior. In some other research that we're doing and developing currently, spearheaded by Megan Deshay, who's now working in New Jersey, and Lindsay Loveros, who's one of my current doctoral students, we're asking the question, if problem behavior is maintained by escape, is it possible to intervene without using escape extinction? Because we've run into a number of situations where we couldn't, for those reasons that I talked about. So escape extinction isn't feasible for one of those reasons. The kid's too big, too fast, too slippery, whatever, or we can't allow the behavior to occur. And what we've been exploring is basically a model where there are 3 environments available to the kid. So one is in the workplace. So we reserve their most preferred reinforcers, like a highly preferred food reinforcer and maybe something like an iPad, and the only place to access those is at the workstation. There's another area where if the child happens to say, like, I'm done, or break, I got to get out of here, they can go to this cool break area, which is where there are things to do, like magazines, other toys, stuff like that. And then third, if they happen to aggress or engage in the problem behavior, they still got a break because we couldn't help that, but there was nothing for them to do. So from a perspective of the matching law and quality of reinforcement, what we would predict is that sometimes the kid would work because that's where the highly preferred items are available. Sometimes the kid would ask for a break because then there's no effort involved. But probably over time, they would stop engaging in the problem behavior that produces nothing but the break with no access to other items. And then once we get that effect, assuming we get that effect, we start to thin out the schedule of reinforcement to make it more manageable. The very first kid we ran this protocol with was about 10 years old, but he was a big kid, and it was virtually impossible to physically guide him. And we didn't want to because we were afraid we would hurt him, or possibly the therapist would get hurt in so doing. So we constructed a baseline condition, which was a typical type of treatment where we tried to continue with the task and keep going even when he was aggressive, but he was producing escape with the aggression. It was basically a mess, and you can see that the problem behavior aggression occurred at high rates across the baseline. Where it says TX, that's where we introduced the cool break area, reserved the best reinforcers for the work area, and then if he aggressed, we gave him a break, but there was nothing to do. It almost immediately suppressed problem behavior, as you can see. We also explored the percentage of the session where his behavior was allocated either to the cool break area or the work area. And that is exemplified by the open circles that are floating near 100% at the top. He spent almost the entire time either taking a break in the cool area or working. And the numbers in the middle represent where we increased the response requirement up to 61 steps in the task. Why did we stop at 61? Well, I'll show you. Because this next figure shows the percentage of the session that he spent at the work table. Notice at the very end, it's all at 100%. He didn't want to leave. He just said, no, I'll keep working. We would say, you're done, you can take a break now. No, I'll just keep going. And he just kept working. So that was our very first exposure to it. We thought it might be a fluke. We've subsequently conducted this with 2 additional kids. The very first one, Joel, never asked for the cool break. So it's a flaw in our design because he never encountered it, but yet he stayed working, kept working at the workstation with a couple of exceptions where problem behavior occurred during the treatment condition. You can see little bumps, and on those occasions he was given the break with nothing else to do. But for him it boiled down to 2 choices, really: either stay at the workstation and get the high potency reinforcers, or take a break and have nothing to do. And this similar results were with our third subject. Yes, a question over there. We might need does anyone have the? Yeah, actually, we'll do this question, but just for the benefit of the audience, we'll do it at the end. But we're already good to go with this one, but let's.
I was just wondering, in the break condition where he had access to nothing, did you experience him trying to escape that area? So I feel like I've done this a lot, and then it becomes like very physically trying to keep him.
No, because that is what was happening before. So what his learning history was is they leave me alone when I engage in the aggressive behavior. Okay. So he basically just like scooted off to this area. It had a little beanbag chair, and he just sat there.
Okay.
And that was what he did. Someone was asking me about that this morning. We've actually applied this, not necessarily in the study, where the person never even moved. We made it so all 3 stations were in exactly the same spot. So if they said, like, I need a break, we gave them the moderately preferred items right there, moved the instructional materials away. If they aggressed, we just moved everything away. And if they continued working, we just had the workstation items available. So you can modify it based on how the person responds. And another thing I want to be clear about is I'm not saying that one should eliminate extinction. It's just that there are some cases where it's impossible to do the extinction. So that's why we did it in these cases. But
Thank you.
good question. So you probably noticed that I talked about using positive reinforcers even though the behavior was shown to be escape maintained. There's some advantages for doing that, and our current research is based on some of the prior research. one advantage is, and I alluded to this last night if you were there in my talk, that it's always been perplexing to me that we would want to use negative reinforcement for compliance with instructional activity, because what it suggests is that the instructional activity should be aversive. And we would, in fact, I think, want just the opposite. We want the instructional activity to be something the student would move toward. So by using positive reinforcement, we might make it less aversive to come to the workstation. And I always use the example of, if you're working out, you might listen to music or watch a video or something like that. It kind of takes the edge off of working out and reduces your motivation to step off the treadmill or quit the exercise. There's also a phenomenon known as location matching. It's essentially conceptually the same as what I just described with the matching law, except with instead of very specific responses, it relates to where someone locates themselves. So if I gave people sitting on this side of the room a $100 bill once a minute, and people on this side of the room a $100 bill once every 2 minutes, gradually people would start to filter over to this side because the rate of reinforcement is richer. And of course, that assumes their behavior comes in contact with that. So what we're thinking is that by using positive reinforcement, kids, students will start to hover around the area where the instructional activity occurs. And in fact, that's what happens. If you kind of put a time plot of where they go, they're more in the region of the instructional activity. And that's a good thing. They're not moving away from instruction, they're moving toward instruction. And by using positive reinforcement, you essentially set up a competition between participation in the instructional activity, and hence the positive reinforcer, and no participation, and hence escape. And usually, positive reinforcers can outweigh just sitting and doing nothing. I mentioned earlier that this can be used as an emergency procedure. So some people will say, well, we're not allowed to use food in my school, or I don't want to use food, and all of that's fine, but sometimes you have to suppress the behavior immediately and then decide where to go from there. So you might have to write an emergency plan that says, we're going to use food reinforcers for now, but that's not the long-term plan. And that's kind of how we have approached it based on Sarah Slocum's research from 2015. This was part of and related to the research she was doing with her Autism Speaks grant. But what she did was she directly compared positive reinforcement for compliance to instructional activity to negative reinforcement for compliance to instructional activity. So in the negative reinforcement condition, which was the open triangles under treatment here, the student was allowed to take a break. So it was kind of like a work break type of arrangement. Whereas in the positive reinforcement contingency, the student was given a positive reinforcer, usually a food item, contingent on compliance. And what we found for Brandon and Allie was that only in the positive reinforcement condition were we able to suppress problem behavior. It went down to 0 for both of those individuals. We also evaluated compliance, and compliance was higher in the positive reinforcement condition for Brandon than it was in the negative reinforcement condition, but it was exclusive for Allie in the positive reinforcement condition. She would only comply when it produced positive reinforcers. She didn't comply or rarely complied when it produced a break from the instructional activity. So there is a good solid evidence base. This is not the only study. There are several other studies supporting the use of positive reinforcement during instructional activity. So recall that I had mentioned that in this fourth step, what we're trying to do is differentiate between behavior maintained by automatic reinforcement and behavior maintained by socially mediated reinforcement. I wanted to talk a little bit about this concept of automatic reinforcement. The term was first used by Skinner in the 1950s in his book Science and Human Behavior, and then again in his treatise on verbal behavior. And Vaughan and Michael in 1982 went back and looked at Skinner's usage of the term and determined that what he meant by automatic reinforcement was that the behavior was operant, but the reinforcement that it produced occurred independent of the social environment. So this would be something like if you're strumming a musical instrument in your room all by yourself and you're hearing the sound of the music, that's maintaining the behavior. There's no one necessarily saying, great job playing the musical instrument. Or if you're smoking a cigarette, no one says, good job smoking that cigarette. You're sitting in your room by yourself doing it. So we know that operant behavior can occur independent of the social environment. And that's what Skinner and Vaughan and Michael were talking about. Now, when we say automatic reinforcement, it does not necessarily imply positive or negative reinforcement. It just means independent of the social environment. So there was a question earlier about automatic negative reinforcement. It appears that some self-injurious behavior is automatically negatively reinforced, but we don't necessarily know specifically what the reinforcer is. So we usually just say automatic reinforcement. Automatic reinforcement should not trump the usage of the specific source of reinforcement if that specific source is known. I once had some graduate students debating out in the hallway outside my office about whether lever pressing by a rat in a Skinner box was socially reinforced or automatically reinforced. And the reason that they were debating that is they thought, well, a person puts the food pellet in there at the beginning, but it seems like automatic reinforcement because the lever press produces it. And they finally asked me, and I said, it doesn't matter. Just say the lever press is reinforced by food, because we know that the food is the reinforcer for it. So there's no reason to debate whether it's automatic or socially mediated. Similarly, with problem behavior, if you know what the specific source is, like let's say a kid is swatting at a desk, wham, wham, and you put a mat on the desk and now he stops swatting, then, and it doesn't make as much noise, then possibly the sound is the reinforcer. And we don't have to say automatic reinforcement, we could say it's reinforced by the sound, although maybe it's the physical contact as well in that example. Problem behavior and appropriate behavior can be maintained by automatic reinforcement. So toy play is commonly automatically reinforced. So it's not inherently a good thing or a bad thing. It's just reflective of the fact that it's the reinforcement is not socially mediated. And this is kind of a picky, I guess, pet peeve of my own, but I just like to clarify that when we're using the term from a technical standpoint, I recommend avoiding use of the behavior is automatic or the behavior is automatically maintained. And the reason for that is I find that people outside of the field of behavior analysis start to get confused that the behavior is something like a reflex. And that's not what we're talking about. Remember, we're still talking about operant behavior, but it's just producing its own source of reinforcement. So I prefer to say the behavior is maintained by automatic reinforcement. In terms of the historical usage of this term, the very first appearance was in 1968 in an article by Tate, but he was talking about something completely different. The type of usage of automatic reinforcement first appeared in the applied literature in 1987 in an article by Lovas and colleagues. And one of my students and I recently tracked that and saw this was the increasing rate of usage of automatic reinforcement in the years since that Lovas publication. So now almost 300, probably over 300 articles, because this ends in 2016, I think, over 300 articles have used the term automatic reinforcement. So this is a problem that a lot of people are facing, and it's coming to the forefront more and more in recent years, but probably has been an issue for a long time. As you'll see, I'll refer to this shortly as an impediment to effective treatment, because in terms of the prognosis for treatment, treatment of automatically reinforced behavior is far more difficult than treatment of socially reinforced behavior. I'm not going to go into the evidence of automatic reinforcement as operant behavior. I think that's pretty clear. And as I mentioned, that socially reinforced behavior, there's a good prognosis for treatment. For when it's automatically reinforced, it's not so good. And I think that we should be aware of that and make sure that we share that information with people when we do an assessment and we learn that the behavior is automatically reinforced. It's okay to say it's not as likely that we can treat this. There's some things we can do, but it's not as, the prognosis is not as good. I mean, we hear things like that from our physicians when we're ill or when a loved one is ill, becomes ill or something like that. So it's just an honest assessment of the situation. It doesn't mean we can't treat it, but certainly we're less equipped to treat it. Why? Because we can't cut off the source of reinforcement like we typically can, or at least sometimes can, for socially reinforced behavior. There is a typical treatment progression for automatically reinforced behavior. Typically, we start with environmental enrichment, so just making sure that lots of preferred items are available to the person, because manipulating items is also automatically reinforced. So the more items that are out and available, the more likely it is that they will compete with the automatically reinforced behavior. Sometimes you have to actually differentially reinforce toy contact to create that reinforcement effect. Sometimes one has to resort to blocking, a brief timeout, or mild punishment because the behavior is producing its own source of reinforcement. And unfortunately, there are times when more extreme punishment or restraint is still sometimes used because the behavior is so dangerous that it can't be allowed to occur. More commonly, you'll see restraint than more extreme punishment. And as I mentioned at the very beginning, overall skill development and early intervention is always in the backdrop. So any of these interventions are only superimposed on the fact that you're still trying to teach important skills to the individual so that those can replace the automatically reinforced behavior. These are some examples of that progression. This is from a study that occurred relatively early in my career when I was at LSU. This individual, Ron, showed automatically reinforced ear picking, where he would pick at the skin behind his ear to the point of bleeding. In the EE plus condition, following a baseline, we simply gave him access to his highly preferred toys, and that was sufficient to replace the ear picking. He started playing with the toys, and the SIB went down to near zero levels. When we went to EE minus, which was toys, but they weren't highly preferred, the problem behavior, the self-injury, came back until we went to EE plus, the enriched environment with preferred toys. It would be nice if we frequently saw this type of outcome, but the truth of the matter is Sometimes that doesn't work. As with Corey, who was a 4-year-old who was in a wheelchair, he would hit himself on the arm and in the face and on the head. And we tried the environmental enrichment approach, EE+, and it seemed like it was going to work at first, but you see a downward trend in his toy play in the EE+ condition and an upward trend in his self-injury. So we next specifically reinforced with praise and food items contact with the toy, because it looked like he, in a sense, didn't know how to play with the toys. And under that circumstance, we were able to get a very nice reduction in self-injury. We returned to baseline, then back to the positive reinforcement and enriched environment, but with decreasing effectiveness. Then we did a new stimulus preference assessment, and when we replaced the reinforcers with new reinforcers, we found that his SIB decreased. So that was a little bit more challenging in that progression. And then finally, Rhonda was a little girl with Rett syndrome. When we did EE-, which was the first condition, enriched environment with just any old toys, it suppressed the problem behavior a little bit. The EE+ was with preferred toys. It suppressed the self-injurious hand-mouthing, which she displayed, to about 50%, but not satisfactory levels. So we tried to reinforce toy play like we did with Corey, diminishing returns. Finally, we introduced a 10-second hands-down timeout, which incidentally, I mentioned her behavior, or that she was diagnosed with Rett syndrome. It turns out there had been prior literature to show that without response blocking or a brief hands-down timeout, differential reinforcement and enriched environment have been ineffective with hand-mouthing and hand-biting displayed by kids with Rett syndrome. So it was only once we introduced that, what I'll call mild punisher, or at least response blocking, were we able to suppress the behavior for Rhonda. Okay, I want to leave some time at the end for questions, so I'm just going to make a couple of final comments and then turn it over for questions. The first one that I'd like to make relates to the functions of blocking. Almost every behavior intervention plan, behavior support plan, whatever I read, includes blocking, and that's fine because I understand that we can't allow people to hurt themselves or hurt other people. But I do want to point out that there have been a number of different studies showing that blocking can serve different functions for different people. So in some cases, blocking functions as extinction, so it makes it so the automatically reinforcing consequences cannot be contacted. In other cases, it's a punisher, like having your arms touched or hands blocked punishes the behavior, and there's a way to distinguish those two. If it's extinction, you have to block every single response, or else it's going to be intermittently reinforced. If it's punishment, you could block every other one or every third one, and it's going to decrease. So Smith et al. And Lehrman and Iwata got different results with the same intervention, which was blocking. In an early study, we showed that blocking can function as positive reinforcement. So just that physical contact might actually increase the rate of the problem behavior. Numerous studies show that it has no effect, or it's neutral. And then some recent studies, one by Rispoldi et al. And one by my group, Jonathan Fernand as lead author, showed that for individuals with very rigid behavior, such as where they need things to be in a certain place in their environment, and if you disrupt that and then block their ability to replace it in the environment, they will become aggressive. So in that case, blocking might actually induce aggression, and you should be aware of that depending on the population you're dealing with. So this is just kind of a Cliff's Notes version of why you should be at least cognizant of the fact that blocking, although it seems like a relatively innocuous component of your intervention plan, might actually be something that is having a specific effect on behavior. And so you need to watch out for that, possibly even test for that. Two final points that I'd like to make. One relates to parent training. Many of you are familiar with behavioral skills training. This is where we actually test for competency at every step along the way, including role play, giving immediate feedback, delayed feedback, and eventually long-term follow-up and monitoring. We have become very confident with behavioral skills training as the best method for teaching parents and other care providers. You'll recall the matching graph that I showed. This is a study we have going on currently. You saw the dark circle data. That was prior to any parent training. There was high levels of problem behavior because there were high levels of reinforcement for problem behavior. After the parent training or post, that's where the open circles are for the same 4 kids. We see that there is less problem behavior and less reinforcement of the problem behavior proportionally to reinforcement of appropriate behavior. So the matching law actually predicts this change in behavior if you can change the behavior of the care provider. And behavioral skills training is the most evidence-based method for doing that. Then the final point I'd like to mention is this about impediments to effective treatment. We've talked about a few of the impediments, such as when extinction is not viable, automatic reinforcement presents its own challenges, medical variables present their own challenges. But one we haven't talked about much is that there are some little understood but viable mechanisms that might be associated with problem behavior, such as with biting. There is a vast literature showing that organisms, including humans, will bite. They'll bite down on something when they encounter aversive stimulation. So it might be a pole, it might be their own hand, it might be another individual. I believe that we've ignored that literature in the treatment of self-injurious behavior and aggression that involves biting. The reason I think we've ignored it is because it has been so clearly shown in basic research. I'll show you a couple of examples. In the upper panel, this is from a chapter written in 1977, so over 40 years ago, when a monkey experiences an aversive shock, they start biting whatever is available to them. It could be their hand, it could be a pole, or whatever. A human, when experiencing an aversive noise, starts biting down. And this makes sense when people used to get surgery before anesthesia, they would give them a towel to bite down on. So people bite down in response to aversive stimulation and pain. Another largely ignored phenomenon is schedule-induced aggression. So if you've ever been cut off in the middle of the road, you might feel that moment of rage or aggression, and hopefully we calm ourselves down, but a lot of people will flip someone off or something like that. Not me, I wouldn't do that. But it has long been known that if you cut off a source of reinforcement for organisms, they will aggress toward a conspecific. Nate Azrin did a whole series of studies with a variety of different organisms that they were getting reinforcers for pecking or lever pressing or whatever, and as soon as that was cut off, they would go aggress toward another member of their species. Now, what's interesting about that is that sometimes in those studies, they had never even seen another member of their own species. So it could not have been learned, right? They're just attacking. So it could be the case that when we take that iPad from a 4-year-old and they start hitting us, we assume that is aggression maintained by tangible reinforcement, but there's a confound in there, possibly, and that is that we're cutting off a source of reinforcement, and so that aggression is induced by reinforcer laws. Similarly, when we place a demand and someone tries to bite us or they bite their own hand, it could be the aversive stimulation, not escape from aversive stimulation, that is maintaining the behavior. Now, I will throw out the caveat that my extension to human behavior is speculative, but I think we should examine it because of all of the data that exists on biting in the presence of aversive stimulation and schedule-induced attack. I've actually looked in some of the behavioral treatment literature. There's a famous study by Iwata et al. In 1990 that examined escape extinction, and I've read this study over and over again. And in most of the cases, when they physically guided the person through the task, the escape behavior extinguished. There was one exception, and they called her Lana in this paper. In baseline, they presented instructional demands and allowed escape when she engaged in self-biting. During treatment, which is the second condition, the first one past the phase change line, they physically guided her through the instructional activity. They placed the behavior on extinction, supposedly, but it didn't go away. She responded differently than everyone else in the study. So I looked, and the description of her self-injurious behavior was, in fact, self-biting. And I've seen this with other people. I've seen kids who are sitting alone behind a wall and no one can see them, and the garbage truck goes by going beep, 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 and they bite their hand. Why is that? Maybe it's something like this. It wasn't until Iwata et al. Went to response blocking that in her case they saw the behavior decrease, which to me suggests the reinforcer was something else, or something else was going on with that behavior, even though it looked like escape behavior. So there's some evidence, if you look closely, to suggest we should be exploring some of these other mechanisms. I talked briefly about rigid behavior. I think that we don't know enough about behavioral rigidity yet. We haven't incorporated that phenomenon into our functional assessments enough. That altering someone's environment has become a functionally aversive stimulus for some of them, and knowing how to deal with that, incorporate it into our treatments is a new challenge. And then finally, methodological limitations. And what I mean by methodological limitations is that sometimes the problem behavior is very low rate or can only happen once. Some examples might be inappropriate sexual behavior. So if someone aggresses towards someone in a manner that is sexually inappropriate, there is no way of measuring that, nor should we, to compare whether at baseline they're doing better than they are in treatment. So it's a challenge to our methodology. Someone was asking about automatic negative reinforcement earlier and how that might interact with medical interventions. Well, that's a challenge to our methodology. How do we examine those things? I think we have a habit in applied behavior analysis of using our research methods, such as our designs, reversal designs, multiple baseline designs, and so on, to develop our study questions instead of having the study question lead us to the appropriate experimental design. So we have it a little bit backwards, maybe just like I had the automatic reinforcement test backwards for so many years. We have our design issues backwards because not all of the problem behavior can be measured as responses per day or responses per week or responses per hour. But that's what our literature is filled with. What do we do about the case of someone who engages in pica where they eat metal objects, and we can't let that happen once. We can't let someone aggress toward another person sexually, or the 6'5", 300-pounder who aggresses toward people with their fist. We can't let that happen even once. So there are a lot of methodological constraints I think we still need to consider, and hopefully as the field moves forward, we'll figure out ways to design our studies to address those features so that our clinical application becomes better than it is in present day, which I think is pretty good. So with that, I would like to open it up to questions for the final 5 to 10 minutes that we have remaining. Does anyone have any questions or comments up front here? She's coming with the mic. Hold on. She's getting her steps in today.
With the automatic screening assessment that was being run, is that being run in a sterile environment, meaning there's no access to toys or anything else the individual can play?
Yes, it's a standard. It's basically an alone condition, but there is an adult in the room. The reason Queerum went to no interaction and why we've gone to no interaction as opposed to true alone is that most school districts do not allow a true alone. Most clinics do not allow a true alone. And given the outcomes, it's actually kind of a bonus to have an adult in there, because then you see that extinction effect when it's maintained by attention, but it also is more compatible with regulations in most settings. Yes, in the back row.
If the functional analysis revealed that the behavior was maintained by attention, would we be able to like get a BT based off of that evidence? Like, will we be able to like request a behavior technician to kind of answer that component? Like in the case where you mentioned the teacher, where she found it difficult to constantly reinforce him in the computer room. In that situation, would it be appropriate for her to like request a BT for that child?
Well, that varies from school district to school district, I think, and a lot of classrooms have like a teacher and a paraprofessional or a behavioral technician or something like that in the room. Most of the cases I am involved with, and it might be different for different people, the behavior has gotten severe enough that in some way before I'm even involved, they have gotten a person involved as kind of an interventionist because they're afraid someone's going to get hurt, or in that case equipment is going to get destroyed. So they're already utilizing the person, and then what we are requesting is just a different utilization of the person. But in the case of walking into a situation where the contingencies are disastrous because there aren't enough people, then I think that would vary from school district and organization to organization about what their regulations are. Up here. She's going to meet you halfway.
Sorry. I was just going to ask regarding the biting and the automatic response. The first thing I kind of thought of is, I think what you were kind of alluding to is an evolutionary kind of basis for some of that.
Yes.
And I think of treatment of specific phobias. And what they found in research with specific phobias or treatment, like exposure treatment or systematic desensitization, is that those that are rooted in evolutionary fears or phobias, like fear of heights and things, that where the person's in danger is more hardwired.
Yeah.
And so it's harder to deal with. Mm-hmm. So I'm wondering if that's something like...
Well, yes. I mean, and again, at this point, I'm just suggesting that could be why some biting occurs. It makes sense.
Right.
And one reason that I think that, and one reason I listed it under impediments, is because I have struggled to treat that type of behavior before. Right. So in terms of the level of challenge associated with it, that's really what led me to believe there's something else going on here, because I would see it and it looked like maybe escape behavior would occur in the demand condition of an FA, but then why is he doing it when he's behind a partition and no one's asking him to do anything,
Right.
and I just heard a truck go by. So I think that's going to be harder to address because there's no social mediation going on, and whether it's automatically reinforced somehow by the offset of aversive stimulation, or if it's just that biting is what people do in response to pain, I think that remains to be seen. But it certainly presents what I believe to be a challenge to treatment.
I think the hypothesis I would have is that, especially when you're dealing with children without language, that
Yeah.
a lot of that other work can't be done.
Yeah.
And so you're just seeing the manifestation.
Well, and if anyone is interested in that topic, I'm not sure I mentioned the author, but there's this really old book called The Handbook of Operant Conditioning, and a hidden gem in that book is by Hutchinson. And Hutchinson spells out all of that research on biting, schedule-induced attack, all of that. I have my students read it all the time because of these issues. I think we're missing something there, and it just strikes me as really odd that that chapter was summarized over 4 decades ago, and all of the behavioral treatment research has occurred in the interim, but that seems to still be out there as a big possibility. The book is called The Handbook of Operant Conditioning. It's by Honig and Staton. Every once in a while it pops up on like the used books on Amazon, and you can get it. But the chapter is by Hutchinson. Back in the day, like when I was in school, it was the book everybody had. So everyone had a copy, but they're getting more and more difficult to find. And, the research in most of the chapters is now outdated because things have moved on in most of the areas, and it's almost all basic research. But that's one area where the research has just kind of stopped, and it seems very relevant to application, but we haven't moved on it. Okay, in fairness to the individuals at home, I think we're going to have to end at this point because we're scheduled to end. If there are more questions or if people want to chat more, I'm happy to stay up here as long as there are no sessions coming in after us. I'll stay and answer any other questions or just discuss comments you might have. But thank you all for attending both at home and in person today, and I really enjoyed your questions. Hope to see you around the conference. Thank you. Oh, we do have an announcement or two.
Yes. Dr. Vollmer, on behalf of all of us, we can't thank you enough for not only your leadership, but your contribution to our field and always bringing it here to our National Autism Conference almost every year. So thank you again. Just a reminder for anybody who is seeking social work CEUs, please sign in and out daily at the registration desk. Please complete an evaluation for this session through the conference website. Again, this is session number 27. And the code for today's session is FLE 526. F as in Frank, L as in Larry, E 526. Thank you, everyone.